Hello, this is Doreen Hughes, and today I'm going to present Understanding Malnutrition in the CDI and Coding World. Our objectives: identify clinical indicators of malnutrition, recognize conditions that are commonly associated with malnutrition, identify the documentation criteria needed to support the capture of malnutrition, construct a compliant query, because we always get denials with malnutrition, and identify how to write a denial appeal letter. Here we've got some little malnourished children. A history of malnutrition. Malnutrition was not universally defined. So in 2016, a group of people came together to try to come up with the criteria that needs to be met. This group was called the Global Leadership Initiative of Malnutrition. This is GLIM. This group included European Society for Parental and Enteral Nutrition, ESPEN, American Society for Parental and Enteral Nutrition, ASPEN, the Parental and Enteral Nutrition Society of Asia, PENSA, and Latin America Federation for Nutrition Therapy, Clinical and Metabolism, FELAMPE. These leaders in clinical nutrition developed criteria to identify malnutrition. To meet this requirement, there should be at least a minimum of one phenotypic and one etiologic criterion met. This criterion can be expanded to show the grading of the degree of the malnutrition, such as grade 1 or grade 2, mild, moderate, or severe, no grade, or severe grade. So why is this important? Well, depending on the study that you read, 40 to 50% of the elderly people that come into our hospital are malnourished. Malnutrition tends to increase morbidity and mortality, readmissions, medical costs, patient falls either in the hospital or outside the hospital, length of hospital stay, their chances of elevated risk of complications and other infections, and risk of skin breakdown. Picture your frail nursing home patient, the patient that requires a busy nurse or tech or CNA to take the time to feed them, and not just them, but probably 6 or 7 other patients in their care. They need to feed them breakfast, lunch, snacks, dinner, and sometimes nighttime snacks. The slower eater may not get to consume as much of their meal before the staff have to move on. Look at this patient in the picture. She has no subcutaneous fat in her face. She has muscle wasting. She's just skin on bones. Do you think she's going to eat very quickly? Probably not. She's going to be a slow eater. She's probably just going to take a few bites or a few sips, because to expend a lot of energy on eating, she just doesn't have that. She's doing everything she can to survive. So why is malnutrition in older adults so prevalent? Well, 1 in 5 older adults have untreated tooth decay, and 2 in 3 of these have gum disease. This limits the older adult from being able to eat and take in nourishment. Look at social determinants of health. Do they have food insecurity? Can they afford the food? Do they have to choose between medications and food? Ensure, Glucerna Boost, etc. are fairly expensive. Underweight does not equal malnutrition. That is something to remember. Now look at this guy in the picture. He has very few teeth, so he's going to have difficulty eating some of the foods that, are generally given to him at night, unless it's a soft or pureed food. With bad teeth or no teeth, it makes eating difficult. So the social determinants of health: supplemental drinks like Ensure a year ago cost about $7 for about 6 bottles. Now it costs about $14 to $16 for the 6 bottles. A patient with multiple prescriptions plus supplemental meal drinks and a low income budget may have to choose between certain meals, certain drinks, buying their prescriptions, maybe even paying for their electricity, or having heating or air, or paying their house payments still. Look at the medications they're on. Many drugs cause dry mouth. Dry mouth makes it difficult to swallow, chew, taste, etc. Are they on medications such as diuretics, narcotics, antidepressants, and antihypertensives? You guessed it, they can all cause dry mouth. These patients are often suck on candies or eat soups, or you might see a lot of gravy on their rice or potatoes or meats to kind of make it really moist for them. They have gelatins and yogurts. As you get older, you also have decreased ability to taste foods, and sometimes they can't even smell the food. So that's usually what kind of gets your digestive system going. So if they're not smelling it and not really tasting it, it tastes kind of bland, they really don't want to eat. So then they kind of start losing weight. The GI tract. As you're looking at the EHR, does your patient have gastritis? Did you know gastritis can cause nutrient deficiencies because it decreases the viability of B12, calcium, and zinc? Other examples that cause nutrient deficiencies are Crohn's disease, ulcerative colitis, gastritis, diverticulitis, etc. These can cause decreased appetite and decreased intake of food and nutrients. People may experience diarrhea, constipation, abdominal pain, and or cramping. Might have bloating of the stomach, abdominal distension, nausea and vomiting. None of this makes you want to eat. So, does your patient have a B12 deficiency? Possibly, which could also make them malnourished. Is the patient alcohol or drug dependent? Does the patient have anorexia documented somewhere in their chart? And does the patient have cancer or recent cancer, chemotherapy, treatments, radiation? That can all make them feel sick and not want to eat. Here I have pictures of the intestines. So you have irritants throughout the intestine, like in Crohn's disease, which can cause you to have abdominal pain, cramping, distension, bloating. Does not make you want to eat at all. It's very painful. And then the colitis ulcerosa also has inflammation of the intestine, which causes the same things. It does not make you want to eat. Other organ involvement that in causes of malnutrition could be liver failure. Look for the decreased taste, social determinants of health. Do they take alcohol and drugs? Liver failure decreases the absorption of nutrients, and with alcohol or drug use, people often forget to eat or drink. They may have nausea and vomiting and often lose track of time and miss meals, and they forget that they didn't eat all day. So then they start becoming malnourished. Cancer patients, this process and treatment can cause wasting disorder, cachexia, and often reduces the quality of the person's life by causing adverse effects from the chemo and radiation. The person may suffer from exhaustion, tiredness, fatigue, loss of appetite, nausea and vomiting, etc., and just does not want to eat. HIV and AIDS. This disease can cause a wasting disorder, which changes to the absorption and the process of the foods and nutrients. This can be caused by the medications used for treatment and the disease process itself. Other organ involvement and causes of malnutrition: heart and lung involvement. Person can present with shortness of breath, lightheadedness, dizziness, unsteady gait, chest pain, weakness, fatigue, nausea and vomiting, etc. This makes it very difficult to stand for long periods of time, to cook your meals, to go grocery shopping, and it even wears them out to even eat their foods. The endocrine system involvement. You have hypoglycemia, hyperglycemia, diabetes, hyponatremia, hypomagnesemia, etc. This person may present with nausea and vomiting, lightheadedness, dizziness, light sensitivity, and if severe, can lead to unresponsiveness and even coma. Again, most of our patients that we see have a lot of these same diagnoses, so we have to watch them and see, are they able to get their meals, are they able to get food at the grocery store and stand and cook. Might need to get them some help if they can't. Early signs and symptoms of malnutrition. We have fluid retention, dehydration, eating smaller portions or poor appetite, feeling weak or fatigue, muscle mass loss, subcutaneous fat loss with sunken features, unintended weight loss, frail appearance, unable to feed themselves, sequela following a CVA such as dysphagia, weak or non-ambulatory, being bedridden, and failure to thrive. When you see any of these signs and symptoms documented in the electronic medical record, then start thinking, does this patient have eating issues and or malnutrition? Obesity and malnutrition. Obesity can exist in an obese person. Large habitus does not mean healthy. Look for malnutrition when you see obese or morbidly obese documented. We cannot talk about malnutrition without mentioning the obesity. Obese patients will often be malnourished. They consume a lot of high-calorie, sugary sweet, and high-carb diets, but they increase in size, and elevated weight does not mean that they are well nourished. Let's face it, nutritious foods are expensive. The food that is unhealthy is the most affordable. And for low budgets, these people can afford ramen noodles, which are very tasty and full of fat and salt and are high in calorie. They can afford frozen pizzas, fast food. This is what I call the college diet because this is what I lived on when I was in college. Can't afford to do that anymore now that I'm of the older generation. Do you see the diagnosis of depression? Often depressed people lose their desire to eat. They feel too tired to shop for food or to cook for themselves. And what is the functional state of the patient? Can they feed themselves? Can they hold a fork or spoon? Do they have Parkinson's disease and shake so badly that the food shakes off the fork before they can even get it to their mouth? A lot of times they just get so frustrated and they give up trying to eat. Did they have a stroke and it affect their right hand and they're right-handed, so now they have to eat with their left hand? Are they able to get the food on the fork with their left hand? Some people aren't ambidextrous and can use both hands, so it's very difficult. We need to follow up with our patients and see where they are. And an Aspen versus GLIM. And is the Academy of Nutrition and Dietetics, and Aspen is the American Society of Parental and Enteral Nutrition, ASPEN, versus the Global Leadership Initiative of Malnutrition. Criteria will be covered on the next slide, but phenotypic means measurable criteria and etiologic means what causes or the type of disease or illness or condition that the patient has that may cause the person to become malnourished. So to meet the requirements set by Ann and Aspen, 2 of the 6 criteria must be met to support malnutrition. However, GLIM requires of the 5 criteria that 1 phenotypic, which is measurable, and 1 etiologic criteria, which is their disease process, must be met to support malnutrition. And Aspen criteria compared to GLIM. Both accept reduced caloric intake. GLIM accepts low BMI. Both accept unintentional weight loss. Both accept loss of muscle mass. Only Ann and Aspen accept loss of fat mass. And only Ann and Aspen accept functional decline. They are the only ones that accept fluid accumulation. But both accept the disease burden, inflammation, and severity or grade of the illness. So again, what is phenotypic criterion? Weight loss greater than 5% over the past 6 months, or weight loss that is greater than 10% over the past 6 months. A reduced caloric intake. The body mass index, BMI, is less than 20 if they are older than 70, or a BMI less than 22 if they are younger than 70. Unintentional weight loss, loss of fat mass, and muscle mass loss is based on validated body composition techniques. What is etiologic criterion? Functional decline and debility, such as dementia. Fluid accumulation usually it's in the lower extremities. You'll see it in the legs and feet. Sometimes in the hands will start to swell. Sometimes the abdomen starts to swell. The disease burden, inflammation, severity grades such as COPD, end-stage renal disease, CHF, end-stage CHF, etc. Here we see a picture of the COPD in its pretty bad state there. The lungs just can't get the air in, so they're having a hard time breathing. Probably can't stand to cook, probably can't stand to go shopping. So again, they're probably on oxygen, pretty bedridden, or sit down, pretty sedentary lifestyle. So they don't really use a lot of energy, so they don't take in a lot of food. Documentation that is needed by our physicians. To help prevent denials, the following info should be documented to support the diagnosis of malnutrition, severe protein calorie malnutrition. And it's up to us as CDI encoders to kind of educate our physicians that they need to put in the time frame of the weight loss. Was this intentional or unintentional? And is this related to a social determinant of health? Are they homeless? Can they not afford food, etc.? Severity of the malnutrition should be addressed. Is this mild, moderate, or severe? And documentation of PO intake. The physician should really document this, and it is easy to find in the I's and O's, nurse's notes, CNA notes. Interventions. What are we doing to treat the condition? Again, this can be found in nursing care plans or dietitian care plans. Document the malnutrition diagnosis on the discharge summary. This is extremely important. We are seeing more denials because the diagnosis of severe protein calorie malnutrition is answered on the query, maybe documented once in the chart, but is not carried over to the discharge summary. So that means that we're doing a great care of caring for our patients in our facility. However, when the patient is being discharged, usually the discharge summary is what goes to the PCP for follow-up care. And if they don't realize that I'm talking about the hospital, the providers, diagnose this patient with malnutrition, they may not be able to take that into consideration and follow up on that. So we need to make sure it gets to the discharge summary. And how is the treatment continued after discharge? Is there a follow-up? So we want the PCP to help follow up on these patients so they're not readmitted. Where can you find this information? Again, we can look at the registered dietitian notes, our nursing notes, our PO, I's, and O's. There should be daily weights. There might be calorie counts. Nursing and registered dietitian care plans. Case management notes for post-discharge needs, food insecurity, social determinants of health can all be found in our case management social work notes. H&P, progress notes, consultation notes, and discharge summary is where the physician should document the malnutrition. Scenario. We have a 76-year-old female is admitted from a nursing home with fever, tachypnea, aspiration pneumonia, depression, failure to thrive, and weight loss. Per the ED note, the nursing home staff stated that the patient refused to eat and seemed to be declining over the past several weeks. She has a history of status post-CVA with right-sided weakness in the right upper extremity. Incontinence and dysphagia. Patient is on parade diet with honey-thickened liquids at the nursing home. 3 months ago, she weighed 150 pounds with a BMI of 25.7. Her height is 5 feet 4 inches, 64 inches. Today, she weighed 110 pounds with a BMI of 18.8. So she's really declined since she's gone into the nursing home. Again, she had a CVA. She's probably right-handed. Maybe hasn't been able to feed herself. She has dysphagia. She might be kind of pocketing the food or very slow to eat. She might even be afraid to eat. So she's starting to lose weight. Her temp was 101.8. Her blood pressure was 110/75. Heart rate 110. Respirations 26. Sats on room air were 89%. She is also taking antihypertensives and antidepressants. So again, those cause dry mouth. So looking at the scenario, would you query for malnutrition? Yes or no? I would query for malnutrition. Which malnutrition key characteristic is documented in this scenario? Weight loss. Weight loss, while all are key characteristics, only the weight loss was documented in our scenario. And number 3, which malnutrition risk factors are documented in this scenario? I said mark all that apply. We have A, failure to thrive, depression, dysphagia, and incontinence. Those were the ones that were mentioned in our scenario. So A, B, C, and D. And here's the answers in case you're just printing it off so you can see them. Questions to consider. What is documented that shows clinical indicators to support the malnutrition query? So think back to your scenario. And do we have indicators to meet the phenotypic criteria? And do we have indicators to meet the etiologic criteria? Remember, phenotypic was measurable. Could we measure her weight loss? And etiologic is the illness. Does she have an illness that would support this? Yes. Gathering your information. The phenotypic characteristics are a BMI of 18.8. Remember that decreased down from 25 point something. And 3 months ago, she weighed 150 pounds, and today she weighs 110 pounds. So this is a 40-pound weight loss in 3 months. So those are our phenotypic. That's our measurable criteria. Our etiologic characteristics. She had acute adult failure to thrive documented in her scenario. She had depression, dysphagia, aspiration pneumonia, incontinence, and status post CVA with right-sided weakness. So those are all supporting characteristics. Here's an example of a query. You say, Dear Dr. X, and the date. And then it says, per the ER note and the HMP, this 76-year-old patient with status post CVA with right-sided weakness, depression, failure to thrive, dysphagia, and incontinence presented to our facility with aspiration pneumonia. It is documented that this patient 3 months ago weighed 150 pounds and today weighs 110 pounds. This is a 40-pound weight loss in 3 months. Her BMI is showing as 18.8. This is down from her previous BMI of 25.7. Our registered dietitian uses the Aspen guidelines and found the criteria support severe protein calorie malnutrition due to the weight loss of 40 pounds and likely caused by the diagnoses CVA with right-sided weakness, dysphagia, and current aspiration pneumonia, acute adult failure to thrive, and depression. She is on antidepressants for her depression and antihypertensive, which both can cause dry mouth. Nursing noted that she is only consuming 10 to 50% of meals. The CNA notes that she is slow to feed. Speech therapy consult was ordered and has been placed. Please clarify if you agree with the registered dietitian's findings of severe protein calorie malnutrition. So we have yes, I agree with the diagnosis of severe protein calorie malnutrition, or no, I disagree with the diagnosis of severe protein calorie malnutrition. And then you always leave a spot for other so that they can clarify. You always want to put a yes, a no, and an other. Other should always be with a yes and no query. And then you put your name, your title, and a phone number where they can contact you. Okay, next we have the appendix of childhood malnutrition. In our facility, we do not have a lot of children, so this isn't really something that our facility uses, although several of you may have a lot of children in your hospital and treat a lot of childhood illnesses and diseases, so you may see a lot of malnutrition in these children. Key characteristics of childhood malnutrition. The Academy of Nutrition and Dietetics and Aspen recommend that that care providers assess these following factors in determining childhood malnutrition. They need to document their food and nutrient intake, their energy and protein needs, their growth parameters, their weight gain velocity, how much and how quickly is the child growing, and are they meeting their benchmarks in height and weight. Their mid-upper arm circumference, MUAC, this is probably the most important criteria out of all the rest, but they all need to be documented, but the mid-upper arm circumference seems to be what supports the childhood malnutrition, and the hand grip strength. Kwashiorkor and marasmus. So here in Kwashiorkor, you see this happens a lot in third world countries, very rarely in the United States, although I did see one case of it at a facility where I worked, and we of course had to have a group meeting with everyone to make sure that that was appropriately identified. They have muscle wasting, they have the big round bellies. On the marasmus, you can see they get this from having a lot of eating a lot of foods such as just rice or potatoes without any protein. So the second one, marasmus, is eating without getting in a lot of protein, and the other one is kwashiorkor. The Ann and Aspen for malnutrition indicators. For a single observation data point, at least one of the following needs to be documented. It needs to be either the weight, height, length, a z-score, the body mass index for the age, a z-score, the length, height for age, a z-score, the mid-upper arm circumference. This is the preferred indicator when a single data point is available. For multiple data points, at least 2 different points in time need to be documented. Rate of weight gain less than expected for children under 2 years of age, and weight loss 2 to 19 years of age. Deceleration of weight for length and height, the z-score, and inaccurate nutrient intake. And here we have our BMI percentiles based on the Centers for Disease Control and Prevention. The adult ones, mild is greater than 17 but less than 18.5. It's a score, a code of E44.1. Moderate is 16 greater or less than 17 BMI with a code of E44.0, or severe, which is a BMI less than 16 with a code of E43. For children age 2 to 19, you have underweight, which is less than the 5th percentile, which is Z68.51. Normal or healthy weight, 5th percentile to less than 85th percentile, Z68.52. Overweight, 85th percentile to less than the 95th percentile, Z68.53, and obese, equal to or greater than the 95th percentile, Z68.54. The CDC recommends the use of the WHO, the World Health Organization, growth chart for children from birth to age 2. The length for the age and the weight of the age are plotted on the graph. Patients that fall below the 2nd percentile line are considered low weight for length. The coding specialist cannot code malnutrition for its severity from the BMIs and the z-scores plotted on the growth chart and circled on the table. The malnutrition diagnosis and pertinent clinical indicators and the severity of the malnutrition must be documented by the provider before it can be coded. So now we're going to our denial appeal letters. So at the beginning of your letter at the top, you'll put your date, you have your letterhead there of whatever company you're with. You have in the left-hand top of your paper, you would have whoever is sending the denial. So it could be Humana, United Healthcare, Blue Cross Blue Shield, etc. Then underneath that, you're going to put all your patient information. So your patient's name, their date of birth, date of service, their account number, anything that's going to identify them that patient denial letter actually had on there. So it might be their claim reference number, etc. Then you'll put dear whomever. So dear Humana. And then below that, you're going to start off with the information that kind of lets them know why you are the specialist that is reviewing this letter. So here I am a certified coding specialist, certified clinical documentation specialist, certified documentation improvement provider, and a mastered registered nurse. I am skilled in classifying clinical data from medical records and assigning numeric codes for each diagnosis and procedure. I have expertise in the ICD-10-CM and ICD-10-PCS, CPT, and HCPCS coding systems. I am knowledgeable in medical terminology, disease processes, and pharmacology. So I've just set myself up to tell them my credentials on what causes me to be able to fight this denial that we have. Then you want to go into the review of the record. So you want to provide information about the patient with the medical history. For example, Mrs. Doe is a 76-year-old female patient who presented from the medical history, including COPD, home oxygen dependent, hypertension, etc. Now include what the patient presented to the hospital with, the chief complaint, the date, and anything else that supports it. So you could say increasing shortness of breath, productive cough, unable to speak in complete sentences. You might want to say she has CVA, she has depression, she has the malnutrition. And then you want to include your HMP, your chest x-rays, your labs, any active problems such as obesity, malnutrition, CHF. And then your nursing assessment notes that are relevant to the registered dietitian notes, wound care notes, etc. Include interventions, treatments, along with the dates that support your appeal. Do not include previous visits unless it supports the appeal and is relevant, such as a CKD stage or a pressure ulcer wound that was a higher stage of the previous visit and is now showing that it has improved. Identify why the DRG or code is substantiated. Add official coding guidelines. When possible, reiterate the criteria that supports the diagnosis in question. Closing remarks with your signature, credentials, and follow-up information. Your place of work, your address, and your phone number so they can call you back. And then I have some resources here for malnutrition. You can go to www.defeatmalnutrition.today. You can go to www.aplaceformom.com, www.nia.nih.gov. This is your National Institute on Aging. Then you have www.nutritioncare.org. and www.ncoa.org. This is your National Council on Aging. Then I have my references. And are there any questions? If you have any questions, you may send them to my email address, dhughes71720@yahoo.com. And if I have other presentations, if you're interested in them on YouTube, and you can search them under Doreen's Academy. And I would appreciate if you would like, subscribe, or leave comments on how I can improve or what you would like for me to do education-wise for you later. Thank you.